what is it? So my today's the job is to dig something in deep regarding the EGFR exon 19 and exon 21 L85 mutation, how the response of the various EGFR TKI differ between these two mutation, and then what are the current recommendation or guidelines to this. So we all know that EGFR is a long gene, and our area of interest for this is between exon 18 and exon 21. So we all know the responsive tumor for a TKI, the mutation is exon 19 deletion, which 747 to 752, and the other mutation which is sensitive to the EGFR TKI is the L858R, which comprises around 41% of the total EGFR mutation seen in the lung cancer patients. So, as we discuss further, we all know that the response of a EGFR TKI compared to the chemotherapy is better, and this has been very well established. The benefit of first-line EGFR TKI in management of metastatic adenocarcinoma lung, where the mutation is positive, and in majority of the patient, the EGFR mutation is seen as discussed between 18 to 21, and the deletion 19, which accounts for around 45% of the total mutations in EGFR, and L858R that accounts for the 40%. And the other rare mutation which can be seen are in the exon 18 and exon 20, which the most important one is the T79 and M0. So coming to the first, second, and third generation, we all know the erlotinib, geftinib are the first generation of EGFR TKI, which binds a reversible binding to the wild type and mutant EGFR, and these are inactive against the T79 and 0 mutants, the erlotinib and geftinib. Then comes the afatinib, dacometinib, which are the second generation TKI, and these two drugs, they binds to the irreversible binding to the EGFR and other HER2 member, the ERB2 and ERB4. And the other important activity which differs or which differentiated from the first generation is the broader activity and some mechanism or some activity in the other rare EGFR mutation, which is more than the first generation. And then comes the third generation, osimertinib, which is a more potent specific inhibitor, particularly effective against the EGFR T79M0, that is exon 20 mutation, and it also irreversibly binds to the EGFR. So first generation, there is a reversible, and second generation has a more wide covalent binding to the other EGFR, like the ERB2 to ERBT4, and the third generation, which has a more specific activity against the T79M0. So how does the response of a various TKI differ between the exon 19 and L85, where the exon 21 activity? So if we dig deep into the various other mutation which is seen in the both exon 21 and L858R, if we dig into deep the other associated mutants. So apart from the other mutation which is seen in the L858R and DEL19, if you see the compound mutation rate which is seen in the exon 21 mutation is around 20%, whereas in deletion 19, the other mutation which is seen is around 5%. So what it means that the probability of a compound mutation, that is further mutation, which is more commonly seen in exon 21 compared to the deletion 19 mutation. Then comes the how this whether this compound mutation has an impact on the outcome. Yes, definitely it has impact. If you see the various retrospective cohort data from, this is one of the paper from China, which has had done the NGS on a cell-free DNA based on that 49 of patients, and what they found that if you look to the response or the PFS rate in the exon 18 compared to the exon 21, there is a clear cut the benefit of the therapy is more seen in the exon 19 deletion compared to the exon 21. Similarly, the OS rate is better in patients who have a mutation in the exon 19 compared to the exon 19. So that means the overall survival is better seen or better in the patient who have exon 19 deletion compared to the exon 21 mutation, that is L5 L85. Similarly, if you see the tumor mutation burden in the both 19 and 21, so we all know that as the tumor mutation burden increases, the probability of response to any further subsequent chemotherapy comes down. So if you and the TMB is negatively associated with the clinical outcome. So if you see the TMB, the load is higher in the exon 21, that is L85 compared to the exon 19. So that means though these are a part of a exon mutation family, but the behavior of a exon 19 differs from the mutation seen in the exon 21. Similarly, the mechanism of resistance on the use of a first line TKI between deletion 19 and L858R, if you see the various mechanism of resistance which is seen in del 19 subgroup compared to the L858 subgroup. See so the most common mutation which is seen in del 19 subgroup is the T970 mutation activation, which is in current era is druggable. Whereas if you see the L858R subgroup, the T790 mutation is less. The unknown mutation, which is more common seen in L858R compared to the deletion 19. So that means the response of a subsequent TKI, particularly the third generation osimertinib, will be better seen in deletion 19 group because of the more commonly seen T790 mutation in deletion 19 compared to the L858R. Similarly, if you see the in vitro sensitivity data of EGFR TKI on a specific cell line, that is BAF3 cell line, which are expressing the various exon 19 and exon 21 L8 substitution. If you see the IC50, so of the various mutation which is targeted with the TKI, if you see the IC50 is the lowest in the dacomitinib group, and it is highest in the geftorinib. So that means the cell these mutation cells are more sensitive to at a lower concentration with the dacomitinib compared to the higher concentration of geftorinib, and the osimertinib comes in between. Similarly, if you summarize that between difference between exon 19 and exon 21, the pre-treatment T790 mutation is more common in L858R compared to the acquired T7 mutation, which is more commonly seen in the deletion 19. And similarly, the sensitivity of a TKI, the indirect data shows that the deletion 19 might be more sensitive to the GFR TKI than L858R. And the rate of concomitant mutation, which I discussed, it is more commonly seen in L858R, making this mutation more resistant to the first line TKI and subsequent therapy. Hence, overall response is less in L858R substitution compared to the exon 19 mutation. So this leads to the difference in the clinical outcome of both EGFR mutation subtypes. So the on further dissecting the data, what we found as discussed, the prognosis of the exon 21 L858R substitution is poor compared to the exon 19 deletion. And if you see the difference between the clinical difference, the exon 21 substitution has more older age, more lapidary growth pattern is more common compared to the deletion 19, which is seen more younger patient papillary. So what this slide seems to is conveying the message that although they are a part of a EGFR mutation, the clinical pattern, the behavior, the response, the mechanism of resistance, the concomitant medicine is entirely different in these two mutations. Hence, the response of a particular TKI differs between 19 deletion and 21 substitution. So these are to be taken as two different entity of a similar of a one mutation type, but these are not the same in terms of all these characteristics which I discussed. So. So this I already discussed, that higher proportion of T790 resistant mutation in deletion 19 that makes the tumor more susceptible or more sensitive to the subsequent line of a therapy, that is osimertinib. So coming to the data of Archer 1050. So this is a study in which the patient of a EGFR mutation positive, they compared the standard care of geftinib compared to the dacomitinib, which is a second generation TKI with a more wider the EGFR inhibition and the pan EGFR inhibitor. So this was the follow-up data which was presented in the ASCLC 2020. So coming to the further dissecting this data of a geftinib versus dacomitinib in Exon, the EGFR mutation positive. So on further maturing the data of around at least around more than 2 year follow-up, if this data again clearly shows that the patients who are have received the dacomitinib both in the exon 19 deletion, the benefit is more commonly or the benefit of a dacomitinib is prolonged and persistent. If you see the median PFS, the benefit is around 16.5 in the dacomitinib compared to the 9.2 in geftinib. Similarly, the exon 21 substitution L858R, the median PFS is 12.3 months in the dacomitinib compared to the 9.8 in the geftinib. So that means this TKI works more potently in both exon 19 and exon 21 compared to the geftinib. Similarly, the other characteristic of the CR, the complete response, partial response, overall response rate, all seems to be better in the both subgroup of exon 19 and L858R in dacomitinib compared to the geftinib, and the hazard ratio for both is similar, around 0.454 compared to and 0.403 in the L858R. So what this slides conveys the message that this dacomitinib is more effective in both exon 19 deletion and the L858 mutation compared to the geftinib in this population. Similarly, the subsequent therapies, if you see the subsequent therapies, definitely the patient who received the second line of therapy, that was more common in the exon 19 deletion compared, and both in the dacomitinib and the geftinib group. Coming to the survival difference, if you see the overall survival, the survival of in a deletion 19 population is around 37 months in the dacomitinib arm overall survival compared to the around 31 month in the geftinib. So there is a clear-cut 6-month benefit survival in exon deletion 19. Similarly, this survival magnitude is furthermore seen in the L858R. If you see the survival in the dacomitinib arm in L858R is around 32 months compared to the 23 months overall survival. So there is a clear-cut 10-month overall survival gain seen with the use of dacomitinib in L858R mutation compared to the geftinib. So that means this drug has a more potent activity in the L858R mutation compared to the geftinib. Similarly, on the longer follow-up, this also maintained, and the both exon 19 deletion and L858R substitution benefited substantially more compared to the geftinib. And this forest plot also substantiates the same finding of a more potent activity of dacomitinib compared to the geftinib in both exon 19 deletion and L858R. And this is one of the slide of interest. If you see the PFS of patient with exon 19 deletion treated with various TKI, definitely the benefit of a exon 19 deletion with flora, that is osimertinib, around 21 months compared to the 16.1. This is for a deletion 19. But if you come to the other TKI, that is other mutation, that is L858R, the dacomitinib seems to have done a little bit better or same. The PFS seems to be around 18 months compared to the 14 months in the flora trial. So there is indirect, though it's not a direct comparison, it's indirect data which suggests that probably L858R substitution mutation may be more susceptible to the dacomitinib when indirectly we are comparing to the osimertinib, which is one of the standard of care at this point. So the side effect, we all know that it's a little bit toxic, the diarrhea, but these are the side effects when the dose is decreased to 30 mg. The side effect profile is comparable to these are the side effect which is seen with 45 mg, which we all know that is little bit toxic compared to the 30 mg. Similarly, this is one of the Chinese scoring system for various recommendation for giving the various TKI. So for Exon 21, they the first line therapy they recommended in there is the either a dacometinib or a combination of erlotinib plus bevacizumab or icotinib, which is not available in India but in China. So for Exon 21, there is some data which shows that the benefit is more in the dacometinib arm compared to the other TKI, including the osimertinib. So in summary, based on the molecular and clinical data, Exon 19 deletion and Exon 21 L85 substitution may be considered as a two distinct subtype of EGFR mutation. Different EGFR TKI has different role for Exon 19 deletion, Exon 21, and the Exon 21 seems to be difficult to treat mutation with more of a compound mutation, more of a TMB, and the response rate is slightly less compared to the Exon 19 mutation. First line treatment with dacometinib was associated with the prolonged PFS and OS in both Exon 21 mutation as well in those with Exon 19 deletion, and this indirect magnitude of benefit of Exon 21 of a dacometinib seems to be more with the osimertinib compared to the osimertinib. So thank you for the listening.